My name is Marit Tanke. I'm a medical doctor and researcher from the Netherlands, and I'm working this year as a Commonwealth Fund Harkness Fellow with Partners Healthcare and Harvard School of Public Health. And I'm going to talk with you about an international collaboration that's looking at high-cost, high-need patients in 7 countries. Let me introduce you to Mr. Janssen. He is a 72-year-old man with multiple chronic conditions. In 2013, he developed colon cancer and spent a fair amount of his time in hospital. His total spending was around $300,000. So Mr. Janssen clearly is a high-cost patient. But the more interesting questions and more important questions in this case are, does the healthcare system provide optimal care for Mr. Janssen? And what part of his care might be modifiable? To understand better how our healthcare system takes care of patients like Mr. Janssen, we developed an international study looking at characteristics of high-cost patients in 7 countries. So the methodology, what did we do? We did a comparison of high-cost patients across 7 countries. We looked at the top 5% high-cost patients of all ages, looking at all medical care. And we excluded all custodial services and long-term care. And the questions we had were, how costly are these patients in different countries? What are their demographic and clinical characteristics? And what are their patterns of utilization? And I'm now going to show you the first results of 4 of these countries. Firstly, the USA. Here we use data, national representative data from the MAPS survey. It's a sample of about 70,000 people. In the Netherlands, a country with 17 million people and with an insurance-based system, we used data from one of the large healthcare insurers, about 20% of the population, about 3.3 million people. In Germany, this is the smallest sample from our study. We used the data 30,000 people from one locally operating insurer in the south of Germany. And then lastly, data from Canada. Here we used data from all inhabitants from the province of Ontario. Countries who also joined the study but are still working on the data are the UK, Japan, and Spain. So the first question we looked at was, how costly are these patients? And first we looked at this from a relative perspective, looking at how concentrated is healthcare spending in the top 5% and the top 1% of the population. So what you see on this slide is in green, the top 1% of the population, orange the top 2 to 5, and then blue is the bottom 95% of the population. The first question we looked at was, how costly are these patients? And first, we looked at relative spending. So how much of the total healthcare cost in a country are made by this top 5% or top 1% of the population. And what you see here, that in the Netherlands and Germany, the top 5% truly makes about 50% of healthcare cost. The green is the top 1% of the population, and the orange is the top 2 to 5%. In Canada, we've seen that costs are slightly more concentrated, and in the US, they are slightly less concentrated. And in general, less concentrated cost means that costs are more equally spread across the total population. Or in this case, that in the US, the money is more evenly spent on the total population than, for example, in Canada. Then we looked at what is the actual spending. And there we see that high-cost patients in the top 5% are about 40 to 100% more expensive than high-cost patients in the Netherlands, Germany, and Canada, with an average patient costing about $40,000 in the USA and $20,000 in Canada. And in the top 1%, we see the same picture, just that those patients are on average about twice as expensive. So the next question is, who are these high-cost patients and how do they differ in the different countries? Well, firstly, the majority of these patients are female, and we see that in all countries. And they're not just the elderly. In fact, about 60 to 70% of high-cost patients in the USA, the Netherlands, and Canada are younger than 70 years. And that's what we see in this distribution. In Germany, the gray bars, we see that they have more elderly high-cost patients. But that probably merely reflects their population distribution as a whole. Because if we look at it the other way around and look at the chance of patients being high-cost per age category, we see two things. One of it is that the older they are, the higher the likelihood of being high cost. And the other thing is that Germany, again, the gray bars, doesn't stand out that much from the US and Canada. If we look further at these average high cost patients, we see that they are clearly have multiple conditions. Here we see the number of conditions from different ICD chapters. And one ICD chapter, for example, is circulatory conditions or mental health. And we see that patients, on average, have between 6.5 and 8 conditions from different chapters. We see fewer clinical conditions in the Netherlands. And then the question is, do patients actually have fewer clinical conditions? Well, probably not. Without going too much into detail, this seems to be a coding issue. Because if we look at this another way and look at the number of different drug categories per patient, we see that an average high-cost patient uses drugs from 8 to 10 different drug categories. And here, one drug category, for example, is drugs taken for diabetes or diuretics. So that was a bit about high-cost patients and who they are. The next step is to look at what are their patterns of utilization. And if we look at where the money is spent, we've seen that most of the money for these patients is spent in inpatient settings. Outpatients is also a large category, and drugs account for about 20% of healthcare spending for these high-cost patients. Interestingly, if we look at, for example, the average number of inpatient days, we see large differences, with the US having on average fewer inpatient days than the other countries, and Germany having a lot more. This tells us that it's not only a question of utilization, but there are large price differences as well. Until now, we've been talking about the average high-cost patients, but we all know that the average patient doesn't exist. And so one of the things where we see that is that the spending pattern of these patients changes as they age. For example, in the Netherlands, you see that in the infants and neonates, there's a very large dark blue bar, and that is hospital and outpatient spending. That dark blue drops in later ages, children and adolescents, and then increases again in the elderly. The grayish blue bar, which you see in the middle, that's mental health care spending, which is one of the most important pockets of spending in the Netherlands in adolescents and young adults. And on the light blue is the spending on drugs. In other countries, we see that these spending patterns differ a bit. So this is the Netherlands again. If we look at Germany, you see that the pattern is roughly similar, just that the spending on drugs is a larger share of the spending at every age group. And then in the USA, the pattern is not so clear, but we see a bit more rehabilitation and post-acute care. That's the darker blue, specifically in the elderly. So in conclusion, what can we say? Well, we have learned that there is a need for these high-cost analysis in all these different health systems. And that across all these countries, healthcare spending is highly concentrated in a small portion of the population. And that those patients are generally older, multiple morbidities, and receive care from multiple sources. And we've also seen differences, total cost and patterns of spending, such as the relatively higher spending on drugs in Germany, mental health care in the Netherlands, and then the rehabilitation post-acute care for the elderly in the US. And then, of course, the question, what are the implications for policy and practice? That depends on the question that you ask. For example, the questions where I started with is, does the healthcare system provide optimal care for Mr. Janssen, or what part of his care might be modifiable? And one of the things that we see and that we learned is that these high-cost patients use care across silos and segments. And so analyzing these patients from a patient-following perspective adds a lot of value and gives a more complete view of the healthcare delivery system and the care that they are using. Wise men have told me that where there's variation, there is an opportunity to learn. So in this case, to identify and prioritize areas of focus for each country. And focal areas may include questions around integration and coordination, because if you see that these patients have, on average, about 8 different conditions, who coordinates the care, at what level, and what is the role of the patient and his or her family therein. Also, thinking about cost containment. For many health systems, cost containment is a big topic, given the rising healthcare cost. But where would you do that for this population? And is focusing on volume reduction, is that the right way to go? And then thirdly, the financial risk coming with this population. Clearly, it's a small proportion of the patient making a lot of healthcare cost. And in this era of shifting accountability also towards smaller providers under accountable care contracts, are they able to bear the financial consequences of this patient population? So what are the next steps? I showed you results of 4 countries. We expect the next 3 probably this fall. And then want to look at potential other areas of interest, like the difference that we see. Is it mainly differences in price or difference in utilization? Are there specific patient groups that we want to look at? And what is the role of the broader health system, such as long-term care or social services? And with that, I'd like to thank all the people who worked with me on this project in all these 7 different countries. Thank you.